Friends, let's take a look at the sharp femur fracture. Here it is an X-ray of the femur bone. Here we can see that the shaft. Here we can see that the shaft part is fractured over here. Now, the sharp femur fracture, it is a medical emergency in orthopedic. It's a medical emergency. Now, whenever a patient of sharp femur fracture comes to you in the casualty or in a trauma center, the first thing we have to assess is the vitals of these patients. We have to assess the vitals of this patient, which includes the pulse, the respiratory rate, and the blood pressure. These things we have to assess. Now, as we know, the sharp femur, it is the strongest bone of the body and it is the largest bone of the body. These are the few MCQs which have been asked in the previous exams. Now, as it is the strongest bone of the body, so to break this strong bone, high amount of energy is required. High amount of energy here means the person will be struck by a motor car or a high speeding driving vehicle. For example, a person was crossing the road and he got hit by a car speeding vehicle, then he has chances of the sharp femur fracture. Now, the difference between the high energy and the low energy trauma. Now, in case of young person, the high energy trauma is required to break this strong bone. But in case of an old man, bones are already weak due to osteoporosis. So even a fall from the standing height, it will result in a femur fracture. Now, what are the various patterns of the fracture femur? We have the transverse, we have the spiral, we got the oblique, we got the segmental one and the combinated one. Now let's understand each one. Now in this picture we can see if the fracture line is horizontal, then it is a transverse fracture. Now the spiral one, here we can see the spiral one. In the spiral one, it has got a rotational component. Now, the oblique one, it does not have a rotational component. The segmental one, when there are more than one fracture line is there, then it is a segmental one. And if you want to look at the combinated one, now look at this picture. When there are multiple fragments of the bone are there, then it is a combinated fracture. Now let's look at the osteology of the femur bone. Femur has got an anterior bow, and on the posterior aspect of the femur, in the middle part, there is a ridge which is known as the linea aspera. This is a site for the attachment of the muscles and fascia. And one more thing you should know, there are how many compartments are there in the thigh? There are the 3 compartments of the muscle in the thigh. Now, when we look at a femur fracture, we have to look at the proximal fragment, that is above the fracture line, and one is the distal fragment, that is below the fracture line. Now, the proximal fragment. Now, the question has been asked previously, what will happen to the proximal fragment in case of a sharp femur fracture? The proximal fragment, it will go into flexion, that is because of the unopposing pull, of iliopsoas muscle. External rotation, that is because of external rotator of the hip, unopposed pull, and the abduction is because of the hip abductors. hip abductors, which are basically gluteus medius and the minimus. Gluteus medius and the minimus. Now if you look at the distal fragment, because of the adductor pull, it will move towards the body, towards the midline. It will move towards the midline of the body. If you look at the individual, it will move, this fracture part will move towards the midline of the body. So it is called varus. And this distal part, it will go into extension due to the gastrocnemius, which got attached over the distal aspect of the posterior femur, which get attached to the distal aspect of the posterior femur. Here it get attached, the gastrocnemius, distal aspect of the posterior femur. Now, the classification system which is used for the femur shaft fracture, it is the Winquist and the Hansen classification. Just remember the name, it has been asked previously. Just remember the name, no need to go through the classification. Now let's look at the case scenario. Now a patient brought to you by the ambulance, and the patient is having a swollen thigh, and when you touch it, the patient is having too much pain. He is not able to get up, he is not able to move, and when you ask him to move, there's a pain is there. And if you look at the foot, suppose the right sided limb is damaged. If you look at the right sided foot, it will be lying externally rotated. Because it is not in continuity with the main limb. So by this we can assume one thing, because from the swollen thigh tenderness, there's some pathologies. Because of that, as there's an accidental history due to trauma, some fracture is there in the long bone, that is the femur. We can assume that. Now second thing is, when we assess the vitals of this patient, the blood pressure, temperature, pulse, respirator, these are very much essential. Because why? Because of two things. The shaft femur fracture is associated with the loss of at least 1.2 to 1.5 liter of blood, and according to the hemorrhagic classification of shock, it will fall into a grade 1 or the class 1 shock. So it is an emergency. We need to take care of these patients. Now second thing, the shaft femur fracture, these patients are associated with the condition known as fat embolism. Now what happens in fat embolism? In fat embolism, what will happen? Out of the bones, out of the fractured bone, the marrow globules, they will come out and they will enter into the capillaries. These globules, they will enter into the capillaries. Now why these capillaries? These globules will ascend up. These fat globules or marrow globules, they will ascend up towards the lung, towards the brain. I'm not good at this. So the brain, brain. So that will result in a situation of confusion, respiratory distress, and petechiae. These petechiae usually are seen in the axilla, and in the conjunctiva. This is fat embolism. So fat embolism is also a serious condition. And the important thing to note about this here is this fat embolism. It will appear after 48 hours of injury. Now, the important question arises here is, like about the important question arises here is about the Thomas splint. If you know about a Thomas splint, whenever a patient comes to the casualty, some residents right now in some institution, what they give, they directly put the limb into a Thomas splint. What will this Thomas splint will do? It will stabilize this Thomas splint. It will stabilize that femur, so there won't be a movement at all. So there won't be a movement. There won't be any movement, and so there won't be any. There will be less pain, less damage to the muscle. So there will be less inflammation. So the patient pain will be relieved a little bit. This way we stabilize it. Now the few points which have been asked previously. If the fracture is open, like femur fracture is open, means the bone is exposed to the environment, then the blood loss could be double. And in case of a closed tibial shaft fracture, blood loss is 500 ml to 1000 ml. And in case of pelvis, it can go up to 2 liters. Now, the most dread complication is fat embolism. We know about this. And how does the case scenario occur? We understood it. Now, how do we manage this patient? The first thing to do is stabilize the patient. We have to assess the vitals. We have to stabilize the patient. Now, if the patient is unstable, then we have to go for the resuscitation process. We have to follow the ATLS guideline. We have to stabilize and monitor with ABGA, acid-base gas analysis, interleukin 6, and the serum lactate level. Now, out of these, the most sensitive indicator of resuscitation is IL-6. IL-6. Now, how do we manage this patient? Like in terms of operative intervention. Like if the patient is adult patient, he is stable vitally, and it is a closed fracture, we can directly go for the antegrade femur nail, which is known as straight femur nail. Now, if the patient is adult patient, hemodynamically unstable, or the patient is having open type femur fracture, then we will go for the external fixator, and we will wait until the patient gets stabilized, or usually we wait for 2 weeks. After that, we fix it with the femoral nail, straight nail. Now there's a special scenario. Like if the shaft femur fracture, now there's a special scenario of the pediatric shaft femur fracture. In this age group, the treatment is different and it is age dependent. Now, for example, for less than 2-year kid, it's a gallows traction that we apply. For less than 5 year, we'll go for the hip spica. For more than 5 year, we go for nailing, and more than 10 year, we also go for nailing. Now, let's look at the difference between these two nails. For more than 5 year, like for the 5 to 10 year age group, we have the two options of the elastic nail, that is TENS, and one is the Enders nail. The TENS is a titanium elastic nail system, and one is Enders. It is the little stiff one, and the nail here means interlock. The nail here means the interlock nail. And here is interlock nail. This is an example of an straight interlock nail. This is how we push it, and there is an anterior bow is also there. Now, the TENS and the Enders nail. Now, if the patient is like 5 to 10 years, the patient is lightweight, then we go for TENS. If it is heavy, we go for Enders. But if the fracture fragment in this pediatric patient is unstable, or like in case it is more proximal or more distal, then we go for the open reduction and internal fixation in terms of plating. In terms of plating. Now the one more special scenario. They will give you a picture of Thomas splint, and they will ask you to identify. And the another thing is they can give you a picture of gallows traction, then you have to identify it just like this. Another thing is they can ask you about the nails. There's a special case, like if the patient is having a sharp femur fracture and the patient also got, if you look at, the patient also got the proximal femur neck fracture, then we will go for the which nail? Then we will, instead of going for the straight interlock nail, we will go for the, guess anyone? And the last point I want to discuss here is about the retrograde femoral nail. Now regarding retrograde femoral nail, here what we do, we insert the nail from the distal aspect of the femur from here, whereas in case of antegrade femur nail, we take an entry, we insert the nail, from the piriformis fossa. That's the difference with the retrograde femoral nail. Now the question is, where do we use it? Now in case of pregnant female, if the female don't want to drop their pregnancy, then this nail has got the low radiation exposure because it takes less time, it's less complicated surgery, so we can afford to do the retrograde femoral nail in case of pregnant woman. The second is bilateral femur fracture. Now the thing with bilateral femur fracture is usually the fracture femur are treated on a traction table. If you go into the operation theater, you see a femur fracture, you see a table is there. There is a hell lot of importance of the table in case of orthopedics. And in femur fracture, we use a traction table, but if there is a bilateral femur fracture, there is an issue with the positioning. So to avoid those positioning issue, what we can do, we can use this, we can put the patient on a simple table and we can go for the retrograde femoral nail. We can do it in less time without any with few risk of complications. And the third is the floating knee. The floating knee means when the tibia also got fractured and the femur also got fractured. So this way, this component is floating. So what we can do, with the same incision, over here, we can do with the same incision. This is how we mark incision. With the same incision, we can put the nail, here and we can put the nail here. And the last one is, if there is a ipsilateral neck fracture, like same side neck fracture, in that case what we can do, we can put the nail from here, like this is the scenario. Okay, we'll put the nail till here and we lock it. Okay, now and for this neck part, what we can do, don't go with the drawing, neck part we can put a dynamic, hip screw. We can go for the DHS. This way we can treat it. And the last one is the morbid obesity. The thing with the morbid obesity is, when you put a nail, antegrade femoral nail, to insert it we have to take an entry from this piriformis fossa, and there is a hell lot of hair. We have to incise over here, then we put an entry all over here to make an entry, then we get inside. Now if the usual thin patient have skin lying over at this place, more obese patient have this much, so we will struggle more, the surgeon will struggle more. So better to go with the retrograde femoral nail, go with the distal femur side. Now the last thing is, let's look at the complication associated with this femur nail, with this femur fracture. The one we know, number one, we know fat embolism. Second, we know there is a risk of heterotropic ossificans. And third is there is a femoral artery or nerve injury, that is very rare. Femoral artery or nerve injury while inserting screws. This can happen in the proximal aspect from the lateral to medial. Now the important thing here is about the after femoral nail insertion, what will happen? These surgery usually taken place in the night in the OT, when the patient came to trauma center, and then the residents rush the patient to the OR and they just fix it. The problem here arises, they are working throughout the day and night, and they put the nail, they're like how they have reduced it and they have inserted the nail. But the one most important thing the resident usually forget, the rotation of this fragment. The mal rotation is a very significant complication that is arising because of the nighttime surgeries. There are other factors like fracture, comminution. There are another risk, complication. Another complication is delayed union. For that we can do what? We can dynamize the nail, in which we remove one of the screw and we dynamize the nail. And another complication, non-union. And the last one is the cortical perforation, because of the mismatch of the radius of curvature of the nail with the bow of